Hello, everyone. Welcome to today's live broadcast, Advances in Diagnosis of Primary Aldosteronism. I'm Christina Jewell of LabRoots, and I'll be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots and sponsored by DiaSorin Incorporated. DiaSorin Incorporated offers the broadest, fully automated infectious disease and specialty diagnostics menu, including best-in-class vitamin D. These quality assays are analyzed on the versatile Liaison Excel platform. DiaSorin provides value through sales, service, and support solutions to hospital and reference laboratories by consolidating their menu in order to streamline processes and increase efficiency. For more information, please go to www.diasorin.com. Before we begin, just a couple of important announcements. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window, or submit your problem through the green Q&A button on the lower left. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located at the bottom left-hand corner of your webpage and follow the process of obtaining your credits. I would now like to introduce today's speakers. We have two speakers for you today, Dr. Alison Woodworth and Dr. Joesph Wiencek. Speaking first today will be Dr. Alison Woodworth. Dr. Woodworth is currently Associate Professor of Pathology and Laboratory Medicine at the University of Kentucky Medical Center. This is where she is also Medical Director of Clinical Chemistry. She's a diplomate of American Board in Clinical Chemistry and currently serves as a director on the ABCC Exam Committee. She is actively involved in teaching and has directed the Clinical Chemistry Fellowship training programs. Dr. Woodworth is actively involved in several national organizations, including AACC and ACLPS. She serves on the board of directors as the chair of the editorial board of the Scientific Shorts Committee for the AACC Academy, and as well as on the executive council of ACLPS. Her noteworthy contributions to clinical and translational research in the areas of sepsis, endocrinology, and maternal fetal medicine have resulted in multiple publications and awards. I will now turn it over to Dr. Woodworth for her presentation. Dr. Woodworth?
Thank you very much for that kind introduction, Christina. I'm very excited to talk to you today about some exciting work that had been done at Vanderbilt with Dr. Wiencek and me. By way of brief disclosure, I'd like to let you know that DiaSorin has funded this study in part through the donation of reagents and small grant funding. Today I'll begin with a brief overview of primary aldosteronism. I'll discuss the disease, its etiologies, and some of its long-term manifestations. Then I'll go on to discuss the new guidelines that have been published by the Endocrine Society that help us in the diagnostic workup of primary hyperaldosteronism. Next, I'll identify some common misconceptions and pre-analytical factors that will prevent accurate interpretation of the laboratory results for the workup of primary aldosteronism. And I'll talk to you about how we in the laboratory can play a role to help the clinical team understand the results of the laboratory tests. Finally, at the end of the talk, we will review the latest assays for assessing plasma renin and aldosterone activity, and Dr. Wiencek will take you through some studies that we did looking at the diagnostic accuracy of different renin assays to predict primary hyperaldosteronism. In order to understand primary hyperaldosteronism, it's important for us to take a step back and understand the Renin-Angiotensin-Aldosterone system, or RAAS. The Renin-Angiotensin-Aldosterone system is a tightly controlled system with the rate-limiting enzyme, renin, being secreted by the juxtalar glomerular membrane cells in the kidneys. Renin activation is triggered by two stimuli, decreased blood pressure and sodium. Renin, the enzyme, catalyzes the conversion of angiotensinogen to angiotensin-1 in the blood. And then ACE, or angiotensin converting enzyme, then converts angiotensin-1 into angiotensin-2 in the lung. Angiotensin-2 is a very potent vasoactivator. And it also acts directly on the adrenal glands to upregulate synthesis of aldosterone. Aldosterone binds to aldosterone receptors in the distal tubule of the kidneys and acts to retain sodium with the expense of potassium excretion. Sodium retention leads to increased water retention, increased blood volume, and ultimately increased blood pressure. The increased blood pressure and increased sodium concentrations then feed back on the kidney juxtaglomerular membrane cells to downregulate renin expression and the RAAS. When the RAAS is dysregulated, one of the forms of dysregulation of RAAS is primary aldosteronism. Primary aldosteronism is characterized by autonomous secretion of aldosterone from the adrenal glands that's not inhibited by sodium or high blood pressure. Primary aldosteronism, also known as Kahn's syndrome, because of Dr. Kahn, the discoverer of the disease, is among the most common causes of endocrine-mediated hypertension. And although it's very difficult for us to classify the total prevalence among all hypertensive patients, it seems as though primary hyperaldosteronism may represent up to 15% of all hypertensive patients. As I mentioned, it's characterized by autonomous, non-suppressible secretion of aldosterone, and this is caused by several different etiologies. Among them, the most common are adrenal adenoma and uni or bilateral adrenal hyperplasia. And far less common forms of primary aldosteronism are caused by familial genetic forms of the disease. Primary aldosteronism should be diagnosed and treated rapidly. If left untreated, it can lead to very severe hypertension, ultimately leading to cardiovascular damage, sodium retention, suppressed renin concentrations, and hypokalemia. Cardiovascular damage can lead to significant cardiovascular morbidity and mortality. And for that reason, it's very important that we have a very good screening test for primary hyperaldosteronism among patients at risk for the disease. The Endocrine Society practice guidelines have been recently updated in 2016. In those guidelines, they lay out a very clear algorithm for the diagnostic workup of disease that begins with a recommended screening test for all patients at high risk for PA. The screening test is the measurement of aldosterone in the plasma and renin in the plasma and calculation of a ratio of aldosterone to renin activity. Anybody with an abnormal aldosterone to renin activity ratio, or ARR, should then be referred to a specialist, either an endocrinologist or a hypertension specialist, for confirmatory testing. The confirmatory testing is typically a provocative testing. It is typically the most common is a saline suppression test. As I mentioned to you, high sodium concentrations will lead to downregulation of renin and the RAAS, which should suppress aldosterone secretion. In a patient that is autonomously secreting aldosterone, infusion of saline or large sodium loading will should lead to suppression of aldosterone in a normal patient, but in a primary aldosteronism, the aldosterone is not suppressed. In a patient with a positive confirmatory test and a patient who is a candidate and who desires surgery, first they should undergo adrenal imaging to determine if surgery is possible through an adrenal CT. If surgery is not desired, the patient may be treated with pharmacological treatment plans. If surgery is desired after adrenal CT imaging, adrenal vein sampling can be performed in order to determine the etiology of the disease, whether it be bilateral or unilateral. Unilateral adrenal adenomas can be removed surgically through an adrenalectomy. All other patients should be treated pharmacologically with mineralocorticoid receptor inhibitors. So as you might imagine, because of the risks of cardiovascular morbidity and mortality, the screening test for primary aldosteronism is very important. So I mentioned that the screening test should only be performed on patients at high risk for primary aldosteronism. The Endocrine Society actually goes on to define who those high-risk patients might be. Hypertensives are defined by them as anybody whose blood pressure is greater than 140/90 millimeters of mercury. In patients that have severe hypertension, greater than 150/100 millimeters of mercury, measured on 3 separate occasions on 3 different days, should be worked up for primary hyperaldosteronism. Others with hypertension that are resistant to at least 3 or more antihypertensive meds, or those that have hypertension that are actually controlled on 4 or more hypertensive meds, should be worked up for primary aldosteronism. In addition, patients with hypertension and hypokalemia, sleep apnea, and a family history of early onset hypertension should be worked up as well. Finally, hypertension and a first-degree relative with primary aldosteronism should lead to the workup of a genetic source of primary aldosteronism. So as I mentioned, the first step for screening for primary aldosteronism is to measure the aldosterone to renin ratio. Aldosterone can be measured, is measured through a mass assay, either radioimmunoassay or a chemiluminescent immunoassay. We'll talk more about that in the second half of the talk. And renin can be measured either by mass or activity. One of the drawbacks of the ARR is that in patients that have suppressed plasma renin activity or plasma renin mass concentrations, because the aldosterone is so high, their ratio can be elevated even in the absence of high aldosterone secretion. And for this reason, numerous experts in the field have recommended that not only do we look for a high aldosterone to renin ratio to diagnose PA, but we also look for high secretion of aldosterone alone. And in the figure on the right, I show you a graph that has mapped the ARR on the y-axis and the plasma aldosterone concentration on the x-axis. And while it's very difficult to give hard and fast cutoffs for what indicates primary aldosteronism with these screening tests, because of the different analytical factors, the different types of assays, and also the numerous interfering pre-analytical factors. The most commonly cited cutoff for the aldosterone to renin ratio is typically 30, whereas for plasma aldosterone concentration itself, they typically cite greater than 750 picomoles per liter, or 27 nanograms per deciliter in conventional units of primary aldosteronism. But numerous papers have suggested that perhaps an aldosterone concentration greater than 15 nanograms per deciliter may indicate, alongside an elevated AR, may indicate primary aldosteronism. So as I mentioned earlier, there are numerous pre-analytical factors that will affect the Renin-Angiotensin-Aldosterone system and thus affect the laboratory testing for aldosterone, renin, and the aldosterone to renin ratio. Potassium status, for example, plays an important role in regulating the RAAS, and in general, hypokalemia will cause downregulation of aldo and a decreased aldosterone to renin ratio. Sodium status and the amount of sodium in the patient's diet is very important to regulating the renin-angiotensin-aldosterone system. A low sodium diet will lead to increased aldo and renin and a decreased aldosterone to renin ratio, whereas a high sodium diet leads to the opposite effect, decreased aldo, renin, and an increased ARR. As many of you know, when posture changes, it affects your blood pressure and also your aldosterone and renin. Aldo and renin are both increased when a patient is in an upright position compared to supine. The ARR, however, is unchanged. Another reason why using the aldosterone to renin ratio is a better measure for abnormalities in the RAAS. Aldosterone and renin are also affected by diurnal variation. In fact, their concentrations are highest in mid-morning, before 10 o'clock, and it's important to consider that when looking at the values for aldosterone and renin. I also mentioned that there are numerous medications that affect the renin-angiotensin-aldosterone system, namely numerous antihypertensive medications. So in this figure, you can see the RAAS and various antihypertensive meds that block different portions of the renin-angiotensin-aldosterone system. Direct renin inhibitors obviously will block the activity of renin, leading to downregulation of aldosterone and also downregulation of the aldosterone to renin ratio. ACE inhibitors will block conversion of angiotensin 1 to angiotensin 2, leading to downregulation of aldosterone and the ARR. Angiotensin 2 receptor blockers, or ARBs, have the same effect. They downregulate aldosterone secretion and the ARR. And finally, mineralocorticoid receptor antagonists, which is the primary recommendation for treatment of patients with PA, will also downregulate aldosterone secretion as well as renin and decrease the ARR. So as you can see, there are numerous both physiological and pharmaceutical factors that affect the RAAS, so it's very likely that some of the testing can be misinterpreted in the workup for primary aldosteronism. And so for that reason, the Endocrine Society has given us recommendations for how to measure ARR, and they have given both pre-analytical or prior to specimen collection and also recommendations for at the time of specimen collection. So their first recommendation is to attempt to correct hypokalemia through potassium supplements. Further, they recommend liberalizing sodium intake, as low sodium diets do affect the concentrations of aldosterone in the bloodstream. They also recommend, if possible, discontinuation of antihypertensive medications that markedly affect the ARR for up to 4 weeks, for at least 4 weeks. Those include the mineralocorticoid blocking agents like spironolactone, potassium-wasting diuretics, and anything that contains licorice. They recommend that, if possible medically, that patients also be withdrawn from other antihypertensive medications like beta blockers, ACE inhibitors, and ARBs for at least 2 weeks prior to collection of aldosterone and renin. Patients can safely be transferred to calcium channel blockers, which are thought to have the least effect on aldosterone and renin. Then at the time of collection, the specimens should be collected mid-morning. The patient should be awake for at least 2 hours in a sitting position for at least 5 to 15 minutes to normalize for the postural effects on aldosterone and renin. So the Endocrine Society goes on to suggest that there are times in which it's impossible to collect those specimens during optimal sampling conditions. And so they have defined several conditions which represent suboptimal sampling conditions. And we at Vanderbilt, as a part of our studies on primary aldosteronism, looked to see how renin and aldosterone were ordered in our patients, whether they were ordered in optimal or suboptimal sampling conditions. And what we found was that when considering the following suboptimal conditions, including patients on greater than one interfering medication, inappropriate collection time, i.e. samples collected after 10 a.m., samples collected when the potassium status was not assessed, or potassium was abnormal, or samples collected when renal function was not assessed or abnormal. What we found was that out of our 200 patient samples that we reviewed, 170 of those were collected in suboptimal conditions. Now, some of these were related to samples being collected while the patient was on medications, and in some cases it's impossible to take the patients off of these medications due to health concerns or significant side effects. However, the large majority was collected either at the wrong time or when potassium status was unknown or abnormal. And so because of this, we've decided that part of this can be corrected with an educational campaign. But the Endocrine Society offers us guidance on what to do about the rest of these. So in their practice guidelines, they state, as I've shown here in the top, if all potentially problematic agents cannot safely be withdrawn, an ARR should be performed and the results considered in light of potential confounding factors. So how can we in the laboratory ensure that a physician is interpreting these results in light of these potential confounding factors? And what we at Vanderbilt did was we implemented a diagnostic management team. So you might be wondering, what exactly is a diagnostic management team? This is a collaborative group of laboratory and clinical experts, and the team comes together to provide evidence-based, patient-specific interpretive reports. It's not intended to regurgitate any guidelines. It's really meant to be evidence-based opinions and interpretations by experts in both laboratory and the clinical arena. A true DMT needs to meet regularly. The interpretations must utilize clinical information in the patient's chart, and they need to incorporate, these interpretations need to be visible in the electronic medical record of the patient. And their intent is to provide clinical value that will help with patient care. Specifically, our intent with the Diagnostic Management Team for Primary Aldosteronism was to ensure a more efficient and effective workup for primary aldosteronism. So we developed this Diagnostic Management Team for the workup of endocrine-mediated hypertension. This team met weekly, and the meetings corresponded to the times that we performed aldosterone and renin testing. When we met, we reviewed relevant clinical history. We considered confounding factors like physiological and medication factors, and we also reviewed evidence like the Endocrine Society and other guidelines to make evidence-based recommendations. On the left, I've shown you an example interpretation for the primary aldosterone diagnostic management team. And here we show sort of what makes this patient high risk and why this should have been ordered. She has uncontrollable hypertension, which is shown here. She was hypokalemic, which is also an indicator of primary hyperaldosteronism, normal renal function. We considered these results in light of the medications that she was taking. She was taking 2 antihypertensive medications, lisinopril, an ACE inhibitor, and amlodipine, a calcium channel blocker. Both of those act to decrease the aldosterone to renin ratio. Then we go on to say that despite that, the aldosterone to renin ratio is so high, greater than 102, and the aldosterone by itself is 20, which is very likely to represent primary hyperaldosteronism. So we recommended that she move on to an endocrine consult where they could do the diagnostic confirmatory testing. We also provide a couple of links to how medications will affect renin-aldo and the aldosterone to renin ratio, along with the recommendations for specimen collections, which I've outlined earlier. So when we implemented the Endocrine Diagnostic Management Team at Vanderbilt, we wanted to do a pilot study to ensure that this was making a difference clinically. So we enrolled patients from 4 primary care physicians that were being worked up for primary hyperaldosteronism. We looked at all ARR orders from these 4 physicians, and we looked at 2 time periods: before implementation of the DMT and after implementation of the DMT. When looking at the patients, we looked at their electronic medical records for clinical and laboratory workup, patient diagnosis, outcomes, and anything that would suggest to us that this improved patient care. What we found was that with respect to both demographics and other clinical factors, there was no significant difference before and after implementation of the Diagnostic Management Team. But what we did find was that before implementation of the PA-DMT, 4 patients had unnecessary diagnostic testing or radiology procedures, and 8 actually had potential delayed or missed diagnoses. After implementation of the PA-DMT, the physicians had close adherence to the Endocrine Society practice guidelines for all patients. We did not identify any unnecessary diagnostic workups or procedures. And of the 5 patients in which we recommended that they have a consult through either endocrine or hypertension, all 5 of them were referred and their diagnostic workup was expedited. And so in conclusion to this part of the talk, I hope that I've conveyed to you that the diagnostic workup for primary aldosteronism is very complex and challenging. The Endocrine Society practice guidelines give us some advice on how to work up this disorder through a screening process and then confirmatory processes. They also recommend that it's very important to consider the numerous suboptimal sample collection conditions for both aldosterone and renin, and to consider those results in the context of those interfering factors. we used a tool called the Diagnostic Management Team at Vanderbilt to consider those factors and effectively communicate how those pre-analytical factors may influence the diagnostic workup and the results of aldosterone to renin ratio. Our next step includes an educational campaign in which we attempt to reduce other suboptimal collection conditions like time of day and potassium status, to expand the DMT to all primary care physicians, which has already been done, and also to optimize the analytical assays that we use for both aldosterone and renin. And you'll hear about all of the work that we had done with respect to assays in the second half of this talk. And with that, I'll just acknowledge the numerous people that spent time working on these studies, including 3 clinical chemistry fellows, Joe Wiencek, Sarah Bissonette, and Jessica Colon-Franco, the leader of the DMTs, Mike Laposada, and our clinical collaborator, Andrea Utz, along with laboratory assistant, Sherry Stafford. And again, we received funding from Dia Soren. And with that, I will pass the microphone back to Christina and allow Dr. Wiencek to give a talk, and I will take any questions at the very end of this presentation. Thank you for your time.
Thank you, Dr. Woodworth. As Dr. Woodworth mentioned, our next speaker is Dr. Joesph Wiencek. Now, Dr. Wiencek is the Clinical Chemistry Postdoctoral Fellow at Vanderbilt University Medical Center. He completed his undergraduate education at The Ohio State University. Following this, he received his PhD in the Joint Clinical Bioanalytical Chemistry Doctoral Program through Cleveland State University and the Cleveland Clinic. Secondary to his graduate research in hematology and coagulation, he completed a comprehensive clinical chemistry internship at the Cleveland Clinic's Pathology and Laboratory Medicine Institute. Currently, Dr. Wiencek is a second-year clinical chemistry fellow at Vanderbilt University School of Medicine. His clinical interests revolve around endocrinology and pediatric clinical chemistry. Dr. Wiencek also serves as an officer for several divisions within the American Association for Clinical Chemistry. I'll now turn this presentation over to Dr. Wiencek. Dr. Wiencek?
Thank you very much for the kind introduction, and thank you, Dr. Woodworth, for providing an exceptional overview of the new and timely release of the 2016 Endocrine Society guidelines, not to mention the quality work we did together with the very first ever endocrine-related diagnostic management team. I also want to say thank you to everyone listening and to everyone involved in getting this webinar together. Now, in my segment of the talk, I'd like to discuss the largest study performed in the United States to determine the diagnostic accuracy of renin mass when working patients up with suspected PA. All right. So to disclose, this research was partially supported by Dia Soren Incorporated, and treble support was provided by AACC. And travel support was provided by AACC to present portions of this talk. Now, to begin, I would like to revisit the diagnostic algorithm provided by the Endocrine Society for the workup of suspected primary aldosteronism. So, as we heard from Dr. Woodworth, in high-risk patients with a positive aldosterone to renin ratio, the Endocrine Society recommends the following diagnostic algorithm to work up patients with the suspected disorder. So as you can see, the entire algorithm for the workup of PA rests on the sensitivity of the aldosterone to renin ratio screening test. So now there are 2 different metrics available to measure renin to assess the Renin-Angiotensin-Aldosterone system and to calculate the aldosterone to renin ratio, namely plasma renin activity and renin mass. Now, each of these Renin measurements have several advantages and disadvantages to their testing, and we will briefly go over them in this presentation. So historically, the use of plasma renin activity has been heavily favored in the calculation of the aldosterone to renin ratio. The test is usually performed by radioimmunoassay. However, plasma renin activity methods for LCMS-MS are becoming more prevalent. In these types of assay, renin from the patient sample activates endogenous angiotensinogen to produce angiotensin 1. For radioimmunoassay methods, there is also a second aliquot for the specimen set at identical conditions but is left at 4 degrees Celsius. And this sample is generally used as a blank for the following calculation that you see in the right-hand portion of your screen. Also, incubation times for these assays can vary from 1 hour all the way out to 18 hours as recommended for low renin specimens. In addition, with the advent of LCMS-MS for angiotensin 1 measurement, there have been many analytical advantages to plasma renin activity, such as the linear calibration curves versus the sigmoidal curves that you would see for the radioimmunoassays. There's a wider dynamic ranges, especially at the low end of plasma renin activity, and the LCMS-MS methods are eliminating the need for radio tracers and blanking incubation. There's also a high-quality calibrant available for angiotensin 1, and that's available from the National Institute for Biological Standards and Control. So there's, like we talked about, there's several advantages and also disadvantages for plasma renin activity. So additionally, the use of plasma renin activity is widely used because it really has stood the test of time. It's one of the first assays that have been out there for radioimmunoassay and the measurement of plasma renin activity. It has a wide clinical acceptance, a huge fan base of clinicians, and a tried and true cutoff for clinically established PA disorders. So, however, there is no doubt about it that there is several disadvantages with current plasma renin activities. They're known to be laborious. They're definitely time-consuming. As recently stated, there's incubation periods out to about 18 hours, and some of them even may rely on radioactivity. Lastly, the LCMS-MS instrument can be quite costly, and as many of us know, also require an experienced technician for running specimens and also overall troubleshooting of the method. On the other hand, there are renin mass immunoassays, which have been around for about 20 years. They were originally immunoradiometric, but are now more automated chemiluminescent immunoassays. And these are becoming more widely available, and they offer several benefits such as walkaway automation, decreased turnaround time, and importantly, instrument connectivity with the laboratory information system. However, renin mass immunoassays are rarely used in the diagnostic workup of plasma or primary aldosteronism due to questionable correlations with plasma renin activity, cutoffs that are based on conversion factors from method comparisons, and an overall unknown diagnostic utility to predict PA. Also, there is a higher potential chance for pro-renin interference, which we'll discuss briefly in a little while. So at Vanderbilt University Medical Center, we performed several studies to determine the diagnostic utility of renin mass to predict PA. Before this was done, though, we performed validation studies for the direct renin concentration assays such as linearity, accuracy, precision, and stability. Following this validation process, we performed a retrospective cohort study utilizing residual EDTA plasma specimens from about 200 adult hypertensive patients being worked up for the disorder. And these residual plasma specimens were then analyzed by the direct renin concentration immunoassay, and then from there we performed chart review basically to determine the patient's history, demographics, pertinent laboratory values, medications, and overall diagnosis. And then this information was then used, sorry, I skipped ahead here. This information was then used to assess the diagnostic accuracy of the aldosterone to renin ratio calculated with either method, get down here, with either method by receiver operating characteristics. And then from there we were able to determine the diagnostic utilities of our methods utilizing the Endocrine Society recommended and our newly defined laboratory cutoffs for a positive aldosterone to renin ratio result in our study population. So in our study, to remind everyone watching, we included patients that were 18 years of age or older with hypertension who had a completed order for plasma renin activity and plasma aldosterone. We rejected specimens from the study if the sample was from, let's say, an incorrect tube type, an adrenal vein sample, and so forth, from the other things that were listed on this slide here. So this is a good point to start discussing the results so we can move into the assay performance characteristics of our study. So here you see, to do this, let's talk briefly about performance characteristics of the assay. So Renin-Mass is a two-step chemiluminescent immunoassay that is run in EDTA plasma. The method consists of magnetic particles coated with anti-renin and pro-renin mouse monoclonal antibodies. And the conjugate is a mouse monoclonal anti-renin antibody conjugated to an isoluminol derivative. The overall assay range stated by the manufacturer is 2.1 to 300 picograms per milliliter. It's also important to note the various interference studies performed by the manufacturer based on the CLSI EP07A2 document, and several of these interference studies are listed here in the screen. So next, let's quickly talk about our linearity studies. We assessed the linearity over the assay range from 2.1 to 300 picomoles per milliliters, and the results of the test were accurate, linear, and precise in the reportable range. From there, let's take a quick look at the within run precision. So here we see two levels of quality control were used on 10 subsequent analytical runs to determine the mean, standard deviation, and coefficient of variation for each level. The precision of the Renin-Mass assay method was determined to meet acceptable criteria by our in-house criteria. Again, let's quickly move on to an important topic and talk about the stability of Renin-Mass. So what you're looking at here is the results from a stability study used to assess 4 common laboratory storage conditions: room temperature, 4 degrees, negative 20 degrees, and negative 80 degrees Celsius. The bar chart illustrates the mean % change from the baseline, and the error bars represent the overall standard deviation. We also put the significant change limit lines in the chart, and those are shown in red. And from this study, we can see that Renin-Mass is stable for several hours at room temperature and for at least 2 months at negative 80 degrees Celsius. So let's talk a little bit about the concept of pro-renin. So pro-renin is the precursor of renin and can be activated by an irreversible proteolytic mechanism or non-proteolytically by unfolding of the pro segment. And several studies state that storage of plasma at refrigeration and ambient temperatures have been shown to lead to an activation of prorenin and therefore conspicuously increase plasma renin activity and direct renin concentration. Now, the blank that's in plasma renin activity assays typically are used to kind of avoid that prorenin activation and kind of alleviate that interference. So overall, it is advised that specimens for renin determination, regardless of assay, be frozen immediately once received in the laboratory, stored frozen, rapidly thawed, and rapidly analyzed. And that is why it's important to perform these stability studies when assessing a new assay, especially with this pro-renin activation. So now let's get on and talk about our method comparisons portions of this. So we utilized the gamma-coat plasma renin activity radioimmunoassay kit and the liaison sandwich chemiluminescent immunoassay, and we performed a linear regression analysis from 200 adult hypertensive patients. Now, even though these are two different metrics to quantitate renin, the overall analysis revealed good correlation between the two methods. Now, it's really important to note here that the majority of cutoffs for direct renin concentration that's used in the aldosterone to renin ratio cutoffs are that are available in the literature, including the new 2016 Endocrine Society practice guidelines, are based on similar method comparisons to the one that you actually see here. And this is why we felt that we needed to take it a step further and assess the diagnostic utility of the aldosterone to renin ratio calculated with this direct renin concentration. Which brings us to the diagnostic accuracy of the aldosterone to renin ratio calculated with direct renin concentration. So through extensive electronic health record review, which I can account for, 200 hypertensive patients being worked up for PA, we were able to determine 189 of these patients were unlikely to have the disorder. The 11 remaining patients were identified to have a likely diagnosis either by the gold standard diagnostic algorithm that you saw in part 1 and the first few slides of my segment of the talk, or by physician-documented diagnosis, or lastly by an elevated aldosterone to renin ratio, elevated aldosterone, and an adrenal nodule being present. So from there, we were able to identify these patients with a likely diagnosis of PA, which was very helpful in allowing us to determine the diagnostic accuracy of the aldosterone to renin ratio calculated with either plasma renin activity or direct renin concentration. And we did this by receiver operating characteristics, which was performed on GraphPad. So as you can see from the analysis, both methods revealed similar diagnostic utility to predict PA. So the area under the curve are comparable between the two methods. So in addition, from this analysis, we were able to really pull out some useful information here to be able to select specific in-house laboratory cutoffs at optimal sensitivity and specificity for both of our methods that are being run currently in-house. So from there, we were able to determine the diagnostic utility of the aldosterone to renin ratio calculated with either plasma renin activity or direct renin concentration at the Endocrine Society recommended and our newly defined laboratory in-house determined cutoffs. So in this analysis, we determined the sensitivity, specificity, and positive and negative likelihood ratios for each method and the respective cutoffs. So as you can see, the Endocrine Society guidelines suggested cutoffs for the aldosterone to renin ratio, for plasma renin activity and direct renin concentration. Plasma renin activity showed superior sensitivity and specificity, as well as positive and negative likelihood ratios here. So you can see that there's higher sensitivity when you're looking at the cutoffs of greater than 30 and then greater than 30 plus 15 nanograms per deciliter for aldosterone when it's calculated with plasma renin activity, and lower sensitivity with the aldosterone to renin ratio with the suggested cutoffs for direct renin concentration. So that was at 5.7 and 5.7 plus the 15 nanograms per deciliter. However, after we determined laboratory-defined cutoffs based on our receiver operating characteristic analysis, we were able to optimize sensitivity and specificities for both methodologies. So you can see the diagnostic utilities became more comparable to predict PA in our study population. So in overall, this presentation, I hope you can see that I demonstrated that the aldosterone to renin ratio calculated with direct renin concentration was really shown to be a sensitive and specific screening test in the workup of primary aldosteronism, especially when in-house validation studies were utilized to maximize sensitivity and specificity. And this is why we feel that direct renin concentration is a viable alternative to plasma renin activity. It really offers a technical feasibility at a high throughput, a lower cost than you would see with the tandem mass spectrometry methods, the elimination of the radio tracers as well. And this is why it's most importantly to state here that regardless of the method that's used to measure renin, due to false positives, plasma or primary hyperaldosteronism must always be confirmed with provocative confirmatory testing. So with that, I leave you our final recommendations, and these are really provided by the 2016 Endocrine Society guidelines, and that is to determine your own in-house cutoffs for your hypertensive population, regardless of the method that you use. So with this, I provide some additional references that could be helpful in your journey in choosing your plasma renin activity or renin mass assays for your specific laboratory. I also want to thank the acknowledgments, or to provide my acknowledgments for the American Association for Clinical Chemistry for selecting this abstract to be presented at this year's AACC annual meeting, as well as all of the helpful work that I've received from my fellow mentor, Dr. Alison Woodworth, and also the laboratory technician, Sherry Stafford, for her help in running the direct renin concentration and aldosterone and plasma renin activity assays at our institution. So with that, I provide an opening for questions. The abstract here is listed if you would like to look it up on AACC's website. And if you have any comments or questions that don't get answered today, I'd be more than happy to take a look into anything that you might would like to discuss. And you can reach me by this email at JOESPH. A lot of people misspell my name, so just make sure you get that correct. So with that, thank you very much, everyone. I appreciate it.
Thank you, Dr. Wiencek. Now, before we get started on the question and answer session, I would like to remind our audience how to submit questions. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. Now, our first question, and Dr. Woodworth, this question is for you. Who is on the Vanderbilt PA Diagnostic Management Team?
Thank you for that question. I think it's really important when developing a diagnostic management team that you include a very well-rounded group of individuals. And so at Vanderbilt, when I set out to develop a diagnostic management team for primary aldosteronism, it was important to find a clinical expert. So we had a clinical endocrinologist who specialized in adrenal function and adrenal abnormalities. And she and I sat together and worked to develop this team. We also want to remember that this is a teaching opportunity, and we use this as a teaching opportunity for our trainees, residents, and fellows in the pathology program, as well as other clinical specialties. And so, but one of the most important aspects of the diagnostic management team at Vanderbilt was that we had evidence-based medicine review team that would attend our sessions, and they're from the library, and they would attend our sessions and they would review the latest literature, and we could ask them any questions, and they would come back with a comprehensive review that really facilitated our ability to make evidence-based recommendations.
Thank you, Dr. Woodworth. Now, Dr. Wiencek, this question is for you. What were the specialties of the ordering physicians in your study?
Thank you for asking this question. Really, when we looked over the 200 patients for this study, we saw that the aldosterone to renin ratio orders were primarily coming from endocrinologists, hypertensive specialists, a good portion, about 10%, were from primary care, and then some just kind of fit in the other care categories, such as cardiology, emergency, neurology, and so forth. So with that, I hope I answer your question.
Now I'm going to direct this question for both of you, but maybe Dr. Woodworth, if you could answer this first. How are you planning to reduce the number of suboptimal specimen collections?
Great question. So during my talk, I mentioned this a little bit, but I feel like the collections that occur after 10 o'clock or when the patient hasn't had potassium supplements, things like that, we really need to identify who is ordering those inappropriately and to sort of launch an educational campaign. Now, as many of us know in the laboratory business, educational campaigns are only as successful as the people that actually receive the education. So I think that there are kind of a multi-tiered way to approach the education. We could meet with the teams. If it is phlebotomists that are under laboratory control, we could discuss with the phlebotomists the appropriate specimen collections, and they could alert the physician and patient to the fact that it's not appropriate. We could talk with the primary ordering clinicians and reinforce the idea of appropriate specimen collections. And also, we have electronic possibilities where we can put in our ordering system, we can say, please note, appropriate specimen collection times are, et cetera, et cetera. So those are some of my ideas, but I wanted to pass it over to Joe to see what his thoughts were as well.
Yes, Dr. Woodworth provided some excellent points there. I think one of the big things that we could help to target these suboptimal conditions, especially just the time of draw, is to really target the people that are ordering this most commonly and providing an educational aspect to say that, you know, this is probably the best conditions that you can get without potentially removing interfering medications and stuff like that, where it would be harmful for the patient. So that's kind of where an area that we could incorporate. Also with our diagnostic management team, since it's very active within our department, in our chemistry division, would be to potentially add that as well into our overall standard interpretation that you saw in part 1 of this presentation. So with that, I hope I provided additional information for that question.
Thank you, Dr. Wiencek. Now, this next question is for you as well. Now, what is your opinion on the conversion factor for DRC to PRA?
Sure, I'd love to answer that question. The conversion factor can be useful when there's times when there's a study that hasn't been extensively performed like we have done at Vanderbilt University. I know that there's another institution out there, and this is how they approached their study. And what was actually comforting to know is that when we did our method comparisons, I met with this other individual and talked to them, and our conversion factor was very similar between institutions with different hypertensive populations being studied for their method comparisons. So with that, again, I hope I answered your question.
Dr. Woodworth will direct this question for you. What happens when you don't get discontinue medications for 4 weeks?
Good question. So as I mentioned in my talk, sometimes it's impossible to take patients off their antihypertensive medications, both for safety reasons and because of the significant side effects. And that's one of the really interesting things that I learned as a laboratory person when I began meeting with the endocrinologist who sees these patients. And she says, you know, while the guidelines say that we should take these patients off their medications, it's nearly impossible in many cases. And so that's why the Endocrine Society has kind of backed off on requiring that patients be taken off these medications in order to measure renin and aldo and calculate the ARR. So they instead have suggested that we interpret the results of aldosterone and renin in the context of those medications, meaning that we know how those medications affect renin and aldo, and we attempt to interpret that in that context. And that is why we at Vanderbilt developed the Diagnostic Management Team, was in order to help the physicians understand what aldosterone and renin and the ARR mean in the context of interfering medications.
Now, if there are no more questions, I would like to once again thank Dr. Joesph Wiencek and Dr. Alison Woodworth for their presentations. Dr. Wiencek, Dr. Woodworth, do you have any final comments for us?
I think with the direct renin concentration, it can be definitely a viable assay. I think people at first may be put off by it, but I think that after going through and really setting up a solid method comparison, potentially a clinical diagnostic study, could be very appropriate for your patient population. Thank you, everyone.
If I might just add to the previous question about the linear conversion between the direct renin concentration and the primary, the activity assay. I think one of the things that we need to remember with that is that, and we have some data to show this, that at certain areas of the linear scale, the correlation isn't so good. So if at all possible, it's really good to develop your own cutoffs, as Joe has showed us, and relate those to actual clinical outcomes, if at all possible. And with that, I'd say thank you for your attention and for listening to the stories about our exciting studies today.
Thank you, Dr. Woodworth, and thank you too, Dr. Wiencek. I would also like to thank our sponsor, Diasorin, for making today's educational webcast possible. Today's webcast will be available for on-demand viewing through April 13th, 2017. You'll receive an email from LabRoots alerting you when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. Thank you for joining us today. We hope to see you next time. Goodbye.